All right. Well, thank you. Everyone is able to join. It's a pleasure today to reintroduce Dr. Aman Chauhan from Sylvester Cancer Center in University of Miami. Dr. Chauhan came to Miami, I guess, about a year ago. Is that right?
Correct.
And really has built a very large neuroendocrine cancer program in Miami, and has done a remarkable job. And this it's a growing population of people in Florida, and as you know, there's a lot of neuroendocrine tumor and carcinoma patients who can benefit from having a specialist relatively close by, and Dr. Chow has done a very good job with that in the whole southeast of Florida. So thank you. Appreciate it.
Thank you, Dr. Strasberg.
And our topic today is poorly differentiated neuroendocrine cancers. So a little bit of a departure from what we normally talk about, which is well-differentiated neuroendocrine tumors. And even though the word neuroendocrine is used to describe both of them, these are really almost completely different cancers, clinically and biologically. And so, Dr. Chauhan, maybe you can talk a little bit about what distinguishes poorly differentiated neuroendocrine cancers from well-differentiated NETs.
Great. First of all, thank you, Dr. Strasberg, and the FLaNET community. You guys have been exceptionally collegial and given us a very warm welcome. And it's really good to extend the neuroendocrine expertise down south because, as you mentioned, we just have a tremendous amount of patients on this side of things. And then I'm realizing Florida is a big state. It might look one state, but it takes several hours for patients to drive from one city to other. So I'm just very happy to be part of the growing Florida NETs community. Neuroendocrine cancer, as you mentioned, is actually not a single disease, and that's what confuses a lot of people. And unfortunately, when somebody gets diagnosed, they log in online, obviously, and try to look for information. Unfortunately, a lot of information focuses on well-differentiated neuroendocrine tumors or lower-grade neuroendocrine tumors or carcinoid tumors, and then they sometimes get confused. So I'm glad that you guys are recording this and making this available and add to the growing wealth of the information about high-grade neuroendocrine cancers. So neuroendocrine cancers are a spectrum of disease. They can, based on how they look under the microscope to a pathologist's eye, be broadly classified into two major classes of diseases. Neuroendocrine tumors, NET, where the T is the main driving word, versus NEC, neuroendocrine carcinoma, also implying poorly differentiated cancer. So that is the first dichotomy. And whenever I meet a patient, initially, I kind of explain this dichotomy that we are dealing with neuroendocrine carcinoma or neuroendocrine tumor. This is such an important critical juncture in our management because from the scans to the treatments to the prognosis, everything is day and night different. These are very different diseases, like you mentioned. So it's the pathology or pathologist who really makes this determination based on a couple of factors: the look of the cancer, what we call morphology, how the cancer cell looks under the microscope, their staining patterns. We throw some dyes on them, different colored dyes that attaches to certain specific proteins on different cancers. And that whole mix of the information makes a pathologist say that we are dealing with a neuroendocrine carcinoma or a neuroendocrine tumor. So one of the important take-home message for our viewers here is always get your pathology reviewed at a high-volume neuroendocrine cancer program, because it is not uncommon for especially these higher-grade neuroendocrine cancers to be mistaken between well-differentiated high-grade NET versus poorly differentiated neuroendocrine carcinomas. To make the matters a little bit more nuanced and complex, in past, there was a very clear distinction between anybody with Ki-67 more than 20% is poorly differentiated neuroendocrine carcinoma, and others are well-differentiated neuroendocrine tumors. In 2017, the WHO changed the classification a little bit, and rightly so. And now we have two different types of grade 3 neuroendocrine cancers. You can have a grade 3 well-differentiated neuroendocrine tumor, and you can also have poorly differentiated neuroendocrine carcinoma, both with high Ki-67 more than 20%. So it's even more important for a pathologist, an astute pathologist, to make that determination and tell us, a medical oncologist, that are we dealing with a well-differentiated high grade or grade 3 or poorly differentiated neuroendocrine carcinoma?
And even though well-differentiated neuroendocrine tumors can sometimes be fairly fast-growing and aggressive, in fact, they range from very slow-growing to very fast-growing. Neuroendocrine carcinomas, poorly differentiated neuroendocrine carcinomas, are almost all even more aggressive than the fastest-growing neuroendocrine tumors. And they're also biologically quite different. So the mutations that lead to well-differentiated neuroendocrine tumors tend to be different from the mutations that lead to poorly differentiated neuroendocrine carcinomas, which tend to be things like P53 or KRAS or RB1. These are mutations that we see in other aggressive cancers. And so different biology, in general, different behavior. Poorly differentiated neuroendocrine carcinomas don't really express high levels of somatostatin receptors. We don't treat them with somatostatin analogs or PRRT. We tend to treat them with cytotoxic chemotherapy. And maybe you can talk a little bit about the traditional treatments that have been around for several decades, and then a little bit about some of the newer treatment options.
Great. So let's talk first about neuroendocrine carcinomas. Very aggressive cancers. They are further of two subtypes. They can be either small cell neuroendocrine carcinomas or large cell poorly differentiated neuroendocrine carcinomas. And both these subtypes can be seen anywhere in the body. I mean, we recently treated somebody with nasopharyngeal small cell, and then you can have thoracic small cell, you can have pancreatic large cell. So both these versions are, I consider them like sister cancers. Maybe small cells marginally more aggressive and rapid doubling time, but overall they're both very aggressive. Doubling time can be as small as 2 weeks. So the urgency is really critical there. So if I have a diagnosis with high-grade neuroendocrine cancer, we have to see them right away, start chemotherapy based on the staging and other factors right away. These are the patients who cannot wait. So urgency in management is critical. Now, regarding how do we go about managing these cases, big picture management involves chemotherapy. However, very important to first stage the patient. If you are dealing with a limited stage disease, or for that matter, stage 1, 2, or 3, early stage, sometimes we get lucky and we find patients incidentally in the early stage. Then based on what organ we are dealing with, we might go for a surgery followed by chemotherapy, versus chemotherapy shrink the tumor, then undergo surgery, or a mix of chemoradiation followed by a surgery. And we have seen and done all of these permutation combinations based on what organ we are dealing with. Things might be different for ovarian small cell versus bladder small cell versus esophageal small cell. Having said that, let's focus more on metastatic disease, high-grade neuroendocrine cancers. These are by far probably 80% of our patient population. So by the time we diagnose high-grade neuroendocrine cancer patient, unfortunately, the cancer is already spread and invaded liver, lymph nodes, bones, or other organs. The standard treatment for this entity has been platinum-based chemotherapy, the carboplatin etoposide or cisplatin etoposide. And this spans back almost when I was born, 1980s, we're talking about. Previously, we used to use very harsh and toxic chemos like vincristine, adriamycin, cyclophosphamide, were very toxic regimens. And in the 1980s, we figured out that these regimens versus platinum doublet, the carboplatin etoposide, equally effective and less toxic. So that really changed the standard of care. But fast forward 5 decades, we are still stuck with those chemotherapies, not because there are not other better treatments, it's just it is so effective. If I have a high-grade neuroendocrine cancer patient, 8 out of 10 will respond to this. So that's why this is very effective. It's very important to start right away. The issue with this chemo is the durability of response. So although most of the patients will benefit initially, the duration for which the response is sustained is very short-lived. can range from 2 months to 6 months in most patients. Yes, there are times we see patients going all the way a year, but most commonly we see that this first-line regimen is able to control the disease for about 4 to 6 months. That's the current standard of care, unless we are dealing with small cell lung cancer, which is a unique entity in itself, because about 14 to 15% of all lung cancers are small cell lung cancer. And there we know adding immunotherapy like durvalumab and atezolizumab has shown benefit in terms of overall improvement in disease stability. Not only that, we also know last World Lung meeting, traditional data used to tell us that the 5-year survival for small cell lung cancer was only 7%. We have now doubled that to almost 14% in the era of immunotherapy. It's a small bump, 14%, but we have almost doubled. So the field is definitely moving forward. What we don't know, that extrathoracic or GI high-grade neuroendocrine cancer patients, would they benefit from addition of this immunotherapy? There's a national study going on looking into that to answer that question. Currently, my standard of care or treatment of choice is platinum doublet, and I wait to initiate immunotherapy.
Yep. And there are some other regimens. We've adopted the platinum etoposide, which is either cisplatin etoposide or carboplatin etoposide from small cell lung cancer. But there are other regimens that are used in gastrointestinal cancers that might work equally well or even better for neuroendocrine carcinomas that originate in the GI tract. And they're talking about things like FOLFOX or FOLFIRINOX. In fact, there'll be a paper published shortly about first-line FOLFIRINOX for gastrointestinal neuroendocrine cancers. This is a very aggressive regimen. It might work a little bit better than platinum etoposide, but certainly not a dramatic paradigm shifting change. Maybe a slight benefit at the expense of a little bit more toxicity. So let's talk a little bit more about immune therapy. First, with standard immunotherapy, like the checkpoint inhibitors, PD-1, PD-L1, and CTLA-4 inhibitors. These are drugs that basically target the interaction between cancer cells and lymphocytes. This interaction typically inhibits the ability of the immune system to target the cancers, and these drugs reverse that. So there's been quite a range of outcomes with drugs like ipilimumab, nivolumab in neuroendocrine combinations.
I think I had a little lapse in the network. So I got almost everything except for maybe the last 25. So you were talking about Ipi-Nivo.
Yeah, and what the data says about that and what your experience has been.
Great.
Sort of as a second line treatment.
Gotcha. So I'm a big believer in immunotherapy. The reason is because when it works really well. I think all of us have, unfortunately, very few, but we do have these patients who have now 3, 4, 5 years with exceptional response. And that's the promise of immunotherapy that we just don't see with chemotherapy-based regimens. So immunotherapy, for the unversed here, these are the class of drugs. Unlike chemotherapy, they're not really toxic to cancer cells by themselves. They really rev up your immune system and make your own body's immune system fight against the cancer. For the longest time, most of the clinical trials testing immunotherapy, and by them I mean classic immune checkpoint inhibitors, have been frankly very disappointing and negative, at least for the well-differentiated tumor category. I was involved in Ipi-Nivo studies with NCI-CTAP, again with combination cabozantinib. We didn't really see anything positive or exciting until the SWOG DART 1609. That was again a cooperative group study, a smaller study testing Ipi-Nivo combination in various rare cancers. And one of the arm on that rare cancer group was neuroendocrine cancers. And within that, they did a subgroup analysis, high-grade neuroendocrine cancer, and they found that, okay, when we give Ipi-Nivo to high-grade neuroendocrine cancers, there is a subgroup, maybe about 25-30% patients who may benefit. It's a very small sample size. We're talking 18 patients. So we're grasping at the straws, but when the bar is so low and we don't have good treatment options, that itself was very provocative, and it is now an NCCN recommended, although very weak recommendation, what we call category 2B recommendation. So I often use Ipi-Nivo at some point, maybe not necessarily second line, maybe sometimes second line, sometimes third line, sometimes fourth line. The guidance that I use, my gut feeling, but when to use Ipi-Nivo is really individualized based on what the patient's needs are. So if somebody's rapidly progressing visceral crisis, immunotherapy is probably not the best approach, because even if it works, if the median duration to onset of action is about 6 weeks based on the published data. So it's a very slow acting drug. So I often prefer chemotherapy-based regimen like Dr. Strasberg mentioned, FOLFOX, FOLFIRINOX, and pretty hard hitting because they work right away. Patients are rather asymptomatic, and that might be our window of opportunity to try Ipi-Nivo as a second line. So I use some of these factors to kind of guide my practice. One of the things that I'm consistently noticing between durable responders are patients who have some sort of biomarker which gives us clues towards better immunogenicity. For example, patients having high MSI status. This is very rare in this, but if you have one of those patients who have an MSI high status, you might want to try immunotherapy up like rather sooner than later. Tumor mutation burden is another biomarker that I have been noticing consistently, that if you have high TMP, or for that matter, even high intermediate TMP, that the patient tends to have more durable response. And this is not just me, even in small cell lung cancer world, the BMS, when they were testing Ipi-Nivo and Nivo in various small cell cohorts, they did find 1/3 of the patients had high TMP, and those are the ones which benefited from checkpoint inhibitor the most. But we don't really have a good validated biomarker to really say you should not get Ipi-Nivo or you should get Ipi-Nivo. So everybody needs to get a challenge or a trial of it till we have better data. How do I sequence second line versus third line is really based on individual patients, my practice.
Yeah. So these are all good points. I should mention, though, the few exceptional responders that I've seen have responded very quickly to immunotherapy. So I wouldn't necessarily use that as a, rapid progression as a contraindication. If patients has progressed on standard treatment, and you think it's worth trying, I think you can do it. But again, it's important to emphasize it's probably, in the real world, about 10 to 15% of patients that have some response, but only about 1 in 20 or about 5% that are long-term responders, meaning they go into remission and stay in remission with immunotherapy.
And Dr. Strasberg, if I may, I'd like to kind of give a small plug. Again, I'm a big believer of this whole field of using Ipi-Nivo in our patients. So we are designing a trial for high-grade neuroendocrine cancer using Ipi-Nivo as a backbone and adding an oncolytic virus, which is a bioengineered virus, very specific for high-grade neuroendocrine cancers. The virus was originally studied at Memorial Sloan Kettering and Dr. Charlie Rodin's lab. They have published beautiful data in high-grade models, but the tumors completely disappeared. We then added Ipi-Nivo to the mix in the animal models and sustained durable responses. So we are taking that concept from lab to our phase 1 clinic, and I expect in the next 5 to 6 months, hopefully we should be able to put first patient in the study.
All right, that's very exciting because as you all know, the clinical trials in this disease have been few and far between. But that sets the stage to talk about the new and exciting development, which is DLL3 targeting bispecific antibody therapy. So maybe you can talk a little bit about that.
Yes, so finally looks like we are making some breakthrough. Unfortunately, this area has been marred with a lot of failures, just like our pancreatic cancers. Very challenging disease. Not that we were not trying. we are finally seeing some hints of successes. One of the probably the flag holder where we're seeing the most success, most promise is this class of drug called BITE antibodies. BITE antibody are a class of drug. It's an immunotherapy drug which stands for bispecific T cell engagers. So I'm going to try to simplify it for our viewers. So bispecific T cell engager, it's an antibody which has two arms, bispecific, bi. One of the arm engages the T cells. That's what the name alludes to, T cell engagers. That's your own T cells, your own host immune system. The other arm of this attaches to a protein called DLL3, which is highly expressed in high-grade neuroendocrine cancers, be it small cell lung cancers, be it large cell neuroendocrine cancer, or any neuroendocrine cancers throughout the body. That's our current understanding. So this class of drug attaches to DLL3 on the tumor and T cells of your own body and brings them closer. The concept's very straightforward. When you do that, the T cells are then activated and starts an immune cascade of inflammation, which then destroys the tumor. Does this concept work? Based on the data from early phase trials, those are phase 1 trials from Amgen as well as BI, the data looks very provocative and very, very exciting. I'll give you some numbers. It seems that almost half of the patients has clinical benefit. That means either they achieve stability in their progressive cancer or has disease shrinkage to almost complete response. Mix of all of this. So we have seen them in about 40% of the patients, 40, 45%. And data is still maturing. We're going to see how the phase 3s read out. But that's very promising. And especially the kind of patients who are enrolled in these studies are patients who are progressing on second, third, fourth, fifth line of therapy. Traditionally, when you are progressed on third, fourth, fifth line therapy, your chance of success with standard treatment is 10% or less. The disease becomes very aggressive and resistant. So if you're able to stabilize or better shrink them in about 40% of patients, that's extremely, extremely exciting. So, so there are a couple of studies testing this concept. I was previously involved in the Amgen study when I was in Kentucky. In Miami, we have the BI study, which is open. Currently, we are waiting for slots nationally, but we are expected to be back on enrolling in about a month. So yeah, the field looks exciting. Regarding so effectiveness is one thing. Is it safe for the patient? So far, it does seems very safe based on the published data. Only 4% of patients had to discontinue treatment because of side effects. So majority of patients were able to continue. The common side effects with this class of drug is fever, chills, because you're engaging the T cells, you're making an inflammation happen. We call them cytokine release syndromes. So majority of patients had the grade 1 or grade 2, or what we call mild type of cytokine release syndrome. So fever and chills. Also, this drug is very early in the development, so we are taking a lot of precautions. So for the first 2 cycles, patients have to be admitted. We give the drug, we watch them for 24 hours for any potential side effects, and then release them. As they get more and more treatments, we get more comfortable. So after 4 weekly doses, it becomes outpatient with a longer follow-up, about 6 hours, and then second cycle onwards, completely outpatient, and we don't even need to do weekly treatment. We just move to once every 3 weeks. So it becomes more and more patient and user-friendly. But right now, since it's in early phase drug development, so we are, it can be taxing to the patient. So they need to fully understand the requirements and the burdens that comes with it. But so far, the data looks very promising. And if I have to bet on any particular drug right now, this seems to be coming on the top, just as an unbiased scientific observer. There are other exciting concepts under investigations for different subsets of high-grade neuroendocrine cancers. A lot of drug development are spearheaded in small cell world for us, and then they later on drift down towards extrathoracic high grade. So I've yet to see how the data matures for VEGF inhibitors and checkpoint combination. There are some positive studies from China with even overall survival benefit in frontline small cell lung cancer space in a large randomized phase 3. We now need to test those combinations in the Western populations because there could be difference in the patient population and genetics. PARP inhibition, checkpoint combination is also another area of active research in this area. And then there are a lot of DNA damaging agent. I was myself involved in a study which stemmed out of NIH, testing latest ATR inhibitors with topotecan. And we enrolled lung cancer as well as extrathoracic high-grade neuroendocrine cancer. And that data is actually in public domain. We just recently published in JAMA Oncology. Surprisingly, there was no difference in PFS, but there was difference in favor of treatment for OS. So we are still trying to understand that. But just to kind of, for our viewers, that there are different agents that are currently being investigated, with DLL3 BiTE being the most promising one of the lot.
Yep. And I also want to point out that when the trial opens up again, hopefully in a month or two, we will probably be able to offer it at Moffitt as well. We're working on trying to open that trial. It opened up and closed very quickly, the initial cohort in the United States, simply because there was so much enthusiasm for the drug and patients enrolled very quickly. I think we've covered a lot, and I know you have a flight to catch, so I want to now open up to questions if anyone has any.
Please feel free to unmute and talk. It's a completely open forum, or put your questions in the chat.
Rohan, by the way, great to see you.
Oh,
Rohan
thanks.
is joining
Same here,
us from
Doctor.
Bangalore.
And from
Bangalore
Goa.
or Goa?
Goa.
Goa.
More exotic.
Goa is like Key West of India.
Absolutely. Nice to see you, Doctor. I missed the last meeting of our group, so it's always
Great.
just helpful learning from you, and then probably just giving out information here in India to a lot of people who reach out.
Thank you so much for doing that.
No,
Rohan.
Doctor. Thank you for your time.
Just a small primer. Rohan, unfortunately, has experienced one of the family members with rectal high-grade neuroendocrine cancer, so he knows firsthand, how important it is to drug development, drug discovery for this rare but very aggressive disease type. So,
in fact, I did manage to get my wife onto the DLL3 trial in Germany. But unfortunately, her performance scores were not very good. And the doctor, because he had they were very kind, because Angem people had reached out to the investigating doctor, and they in Germany, and they'd agreed to take her on. But then the doctor very nicely explained to me that it's probably not worth it, mass coming all the way and in her condition, and probably wouldn't really help her. And that's the only reason we kind of stepped off the gas and said, okay, fine, let this nature take its course. But yeah, in fact, I was very excited, and probably one thing that I do hold as a regret is that we came to MD Anderson and something happened. My wife was not happy with what happened at MD Anderson, and we decided to fly back. Though I had an appointment with you, Doctor, as well, to fly to Kentucky. But then she just wanted to get back to the kids, and she was so depressed that we flew back. And somehow I regret that. I wish I had taken her to Kentucky, and then we could have done the DLL when she was in a much better health.
Rohan, no regrets. You can, at that time the field was so early, we had zero data, so you had to do what you had to do. And you have young kids, you have to go back. Please don't live with any regrets. We didn't know how it would pan out. Okay.
Thank you, Doctor.
Dr. Hayder, good to see you.
Likewise, thanks for your time. I want to share a question that comes up a lot in clinic, and how your approach and when you consider this. So there's always a a question of when is surgery appropriate, when should we pull that a multidisciplinary care in neuroendocrine carcinoma. And of course, we view this as a systemic disease that needs prompt systemic therapy to address metastatic or microscopic disease as well. But can you outline where, or in which circumstances then surgery can be pulled in?
Great question. And we do come across those instances. And I'll give you a couple of examples. Currently, I'm treating a patient with local regional lower esophageal small cell cancer. Luckily for the patient, it's MSI high. So we are throwing the kitchen sink at it, radiation, chemotherapy, and immunotherapy with the goals of getting this patient resected and a shot at cure. I now have a series of patients where we were able to anecdotally do the multimodal treatment with chemoradiation, and then were able to salvage with surgery, but they had great response. Now, this is only doable if it is early stage. So stage 1, 2, and 3, everything is a fair game. We have also seen success with this approach in bladder and gynecological high-grade neuroendocrine cancers, because there we often find them or diagnose them early. The patient has a pap smear. We are able to kind of find them at their FIGO early stage. In our GI world, many times, unfortunately, patients present with liver metastases. There, I almost never foresee a role of surgery. In fact, unlike our well-defined NETs, where there could be still role of cytorectal surgery, it's because these are big surgeries. There's a lot of recovery time. It's very rapid tumor growth rate, and we lose more ground by doing surgery and then and have to have a cooling off period to start new chemotherapy. So I usually dissuade patients from metastatic disease or NEC, even for that matter, grade 3 well-defined NET. The only time I've gone for surgeries for grade 3 well-defined NETs is when we have really had a great response to some of the chemos. Patient has shown stability for almost a year or longer, or exceptional response. I just don't, these are very aggressive biology patients, and I just don't feel that they benefit from surgery. And that's just my personal preference. Now, we all have those patients present with obstruction, and there's a life-threatening situation. You have to bite the bullet and do surgery for diversion, and things like that. Barring those examples, I often don't foresee use of surgery in metastatic disease or NEC.
Mhm.
Would you operate on an early stage esophageal neck?
I often like to start off with chemotherapy because the risk of micrometastatic disease early on is so high, and I've seen that time and again, that the surgeon goes in and the lymph nodes are positive, and they are sent to me after the fact because they diagnose a neuroendocrine cancer. The only exception to that rule is lung. So the thoracic large cell neuroendocrine cancer has a lot of good data based on stage versus outcome. And there, yes, if they are stage 1, yes, by all means, go for surgery, and then we can evaluate for pathological staging and then do adjuvant therapy that might include chemo or radiation based on final staging. But in other extrathoracic high-grade neuroendocrine cancer, I almost always want to give them chemo first, understand the biology, and then hopefully get them to a point where we can cure them if they're early stage.
Yes, that's my approach as well. I think to summarize, one must take the opportunity to address future risk of recurrence, and whoever is able to start the treatment first ensures that it's complete. And so starting with chemotherapy, if we have a diagnosis, is ideal.
Yeah, there are certain primary sites where surgery has been shown to be associated with inferior outcomes, even if it's early stage. One of them is esophageal. There's also questions about, primary anal or distal rectal, where the surgery is so large and involves a colostomy bag that it may be best to do radiation rather than surgery, even if it's technically resectable. But yeah, any other primary site in the gastrointestinal tract, I think you can consider surgery if it's early stage, and if you probably after chemotherapy, although these cases are quite rare, because in almost all cases, the cancer has spread outside of the primary site. Does anyone else have any questions?
There is,
Dr.
Um,
Strasberg and Dr. Hayder, why don't let me kind of ask you guys a question. How's your experience with genetic testing and targets or targetable mutations in NEC? And what's your practice? Do you get NGS testing on all the patient and what time and progression or upfront?
So I want to let another participant know that we did receive your question and we're going to answer it after this one. It's in the message chat. But to answer your question, so what we're talking about is looking for genetic variations in the cancer cells. And the purpose of that is to see if there's a target, meaning can we match it to a medication that targets that mutation, and maybe it may be a borrowed medication that's used in another malignancy, but once we have that data point, we can apply for it. And I do prioritize ensuring that we have that discussion in clinic and getting this testing, because as you said, our resource list for treatment is not as extensive as we would like. And so this is an individualized, personalized approach that can extend that resource list for a particular patient with a particular tumor. And I've seen some shared mutations, like for example, for colorectal small cell with BRAF mutations that are seen in other types of colorectal cancer, like adenocarcinoma, and have implemented more targeted therapies. Usually still start with our approach of chemotherapy, because we want to be prompt while we await those results, and then pull that in the future. It also opens access to clinical trials. So there are clinical trials really designed for new medications targeting a mutation. And so that makes our resource list for treatment ever more personalized.
There's a question in the chat. An individual who's about to start chemotherapy with carboplatin etoposide. And the question is, what's the best way to prepare for this? So I'm not sure I have a great answer. I mean, it's important, first of all, to start quickly. Time is important in this disease. You have to be prepared for some side effects. Nausea is one of them, and there should be medication like compazine prescribed to prevent it, as well as medications that will be given prior to the chemotherapy. It's typically given through a port, though that's not mandatory. Just safer to administer intravenous chemotherapy through a port. We often give Neulasta, which is a growth factor that helps reduce risk of infection right after the 3-day cycle of chemotherapy. Hair loss is a side effect, so that's something that, to be prepared for. And then the next question is whether fasting before treatment is beneficial. That's something I've heard patients talk about. I'm not sure that there's a lot of data in the medical literature, but I don't know if Aman or Aman, if that's come about. It's definitely not a standard recommendation, medical recommendation, but I know that it's out there on the internet, and so I don't know what you've heard about it and what the rationale for that is.
I'm
Yeah.
sorry, I'm not a doctor, so I don't have much information, but I did try the fasting bit with my wife, and it certainly brought down the side effects. The nausea and all did come down quite a lot, and she recovered a lot faster from the doublet than she did in the first few cycles. So I mean, but then it could just be that her system got used to the chemo, and difficult to say. But we did notice that there was a benefit in fasting for 24 hours. Do the first day with fasting, and the second day onwards she started to eat when she was on etoposide alone.
Aman or
Yes,
Mehmet,
great.
do you have any comments on that?
Nothing on fasting, to be honest. I think it's an interesting observation. In the same vein, there was a paper, at least some data regarding, if this is about chemo, but sometimes we do chemo plus immuno for the high grades. And there was data that if you do immunotherapy in the afternoon, you saw, I don't remember, it was better results, and it was published in a very high impact paper publication. So these things, is there a gut microbiome angle to it? That's what they were alluding to, how these drugs are processed, and then maybe better side effect profile based on that. But I just don't have data to substantiate, so I don't really tell my patients to fast before. However, what I do tell them, the first cycle is really important. We all learn how the patient responds to the first cycle. So some patients are very, very sensitive to chemo, and they'll have tremendous amount of nausea and vomiting. And these are usually younger patients. They have all their vomiting receptors very intact in the brain, so very, very sensitive. So we understand their needs, and then if we have to ramp up the pre-medication regimens with very stronger antiemetics, we do that before and for the second cycle. And also the other thing that we have at least adopted in the US is addition of a drug called Cosela, which is CDK4 inhibitor, to help with the bone marrow recovery. So in addition to Neulasta, we have another potential drug that can help with almost like 3 lines of bone marrow cell recovery. And it's FDA approved for at least small cell lung cancer. So we can use that with platinum doublet. It's basically for platinum doublet regimen. But sometimes it doesn't work well, then we still have to add Neulasta to it. So for what's it worth? Dr. Hayder, any other?
Yeah, there are small publications about fasting, but I agree that I don't implement it in our practice at present. But I think, you know, we are starting to learn more about supportive mechanisms and like you mentioned, the gut microbiome and how we can optimize our efforts. So I think that is going to be a growing field. And I would add that, you know, in preparing for chemotherapy, that we want to know all side effects. So our you know, goal is to treat cancer and have you thrive. And you know, if you have symptoms, you know, share them, and there are many ways to treat them, so that your subsequent cycles are much more comfortable. And that is always the goal of your treating team.
Well, Lynn had another question about what's considered early stage, and that's the simple answer. It means that the cancer has not spread to other organs from where it started. It could have spread to lymph nodes, which kind of makes it locally advanced. Sometimes that's considered early stage, sometimes that's not, but late stage is when it's spread to other organs, and that's often known as stage 4. Aman, by the way, if you need to board a flight, feel free to duck out anytime, okay?
Thank you, Dr. Strasberg. No, I still have, I think, 10 minutes before
All right.
they'll start.
Sherry had a question about tumors being heterogeneous, so the plan is perhaps to proceed with Capto. I don't know if that means Captozar, meaning irinotecan.
Yes.
Tecentriq, which is a PD-1 inhibitor, immunotherapy, and Lutathera. You know, I don't want to comment on individual cases. That would be you know, this would be an unusual treatment for poorly differentiated neuroendocrine cancer, but you know, I don't want to get too deep inside the weeds of a particular recommendation, because I don't you know, I don't have the information to provide a perspective on that.
Mm-hmm.
I can make a small comment about it, not for this particular case. We are going to be opening a clinical trial for SSTR positive high-grade neuroendocrine cancer, where we will do combination chemoimmunotherapy plus not Lutathera, but similar drug, a PRRT agent, for only those patients who are SSTR positive.
And is that for poorly differentiated neuroendocrine cancers?
So right now in the phase 1 setting, it might include all while we're doing the dose finding, but eventually the trial's looking at small cell lung cancer initially. We find that in small cell lung cancer, at least 1/3 of the patient might have some degree of SSTR expression. Now, is that enough to have a really good, robust response? That is yet to be all teased out. But these high-grade neuroendocrine cancers, they are exceptionally radiosensitive. That's something that goes in favor of them as compared to our well-differentiated, which are maybe not as radiosensitive to poorly differentiated as compared to poorly differentiated. But this is very, very early, so I'm not advocating by any means that you should all get screened with DOTA pads and do these off-label, because very high risk of side effects. These drugs by itself are all marrow-toxic, and then we are yet to understand the degree of side effects, so we are kind of proceeding very cautiously.
So we actually have a study looking at FDG and dotatate imaging in patients with poorly differentiated neuroendocrine cancers to try to figure out what percentage express somatostatin receptors. I can say that it's not an all or nothing thing. somatostatin receptor expression can be heterogeneous, and I think that's what we're going to see in a lot of these cases. Any other questions?
Hi, I have a question.
Yes.
My name is Victoria. Hi, thanks to everyone. Happy to be part of this group. Well, not really, but as a supporting my husband in this journey. My question is, how imperative is it to identify the primary tumor?
Right now, I would say not very imperative.
Okay.
Because we tend to treat these similarly, but if we're talking about poorly differentiated neuroendocrine carcinoma, may I ask what kind of scans have been done to look for the primary?
Sure. He's had a couple of CAT scans and one PET scan.
And this is a regular FDG PET scan?
I believe so. Apologies if I don't know all the exact terms. I don't have the paperwork, unfortunately, open in front of me. It's just, it is at this point at stage 4. So, everything has metastasized. So I think it's unclear of where the primary is.
And where are the metastases?
Well, they believe the primary is either prostate or bladder, and it's metastasized to liver, lung, and spine.
I see. Yeah, so they identified sort of this primary site without being able to pinpoint it specifically. And the answer is if it's a pure poorly differentiated neuroendocrine cancer, it's probably not that important to distinguish between those two primary sites.
Okay, thank you.
Just one small comment to that. The only time I've felt an advantage in kind of either leaving the primary out of the diagnosis if it's not clear, or allude towards, if possible, small cell lung cancers, just because we have just tremendous number of clinical trials access to small cell lung cancers compared to extracellular carcinoma. I mean, it's probably 9:1 ratio. So because of that advantage alone, I sometimes feel if we are non-committal and we don't know, I'd rather not label something as bladder high grade, because it's not really doing us any benefit. The most number of FDA approved treatments are also for small cell lung cancer. The most number of ongoing clinical trials are for small cell lung cancer. So I always try to see if we can fit the picture for small cell lung cancer. Of course, we're not making lies, but if it's clearly, otherwise there's really no advantage. Like Dr. Strasberg mentioned, drugs are very similar. The disease is very much similar in terms of its phenotype.
And we also want to be mindful to start treatment. So I think I've seen sometimes a lot of exploration on scopes and testing and procedures to try to find the primary when it's not going to really direct our treatment, and then we're losing that time of benefit of starting treatment. But I think, in the future, like for example, looking at different primaries and what our starting point is in terms of chemotherapy, like Dr. Strasberg talked about, FOLFIRINOX maybe for those that begin in the colon, or pancreas versus carbotope. And so perhaps in the future, we would change what we're using if that data pans out.
All right, any other questions? All right, well, thanks again, Dr. Chauhan. Really appreciate you taking the time in the midst of your travels. And thanks, Mena, and thank you everyone else for joining. Really appreciate it.
Thank you. Thank you for
Thank
having me
you.
over. Thank you, guys.
Safe travels.
Take care.
Bye-bye.
Thank
Thank you, doctor.
Bye.
Thank you. Bye-bye.
Bye.
Have a good